So, good afternoon, everybody. So, my name is Anthony Ian Dangoy. So, here is my case study for this last semester. So, my case study is here are the patient information. So, the patient is 44 years old. He is male, height of 5 foot 10 inches, with a weight of 330 pounds, admitted on October 17 and had a code full status. So other pertinent information for this patient is with the respiratory history, the patient had OSA or sleep apnea, smoking history, he is currently smoker and smoke a half pack a day. But then medical history, he had a myocardial infarction, diabetes, hypertension, and hyperlipidemia. So one of the things that I would like to discuss is based on his medical history. So like the hyperlipidemia. So with the hyperlipidemia, it means that the patient had high cholesterol levels. So with the high cholesterol levels, that leads to a plaque buildup in the arteries, which could lead to any clot formation. And one of the things that causes hyperlipidemia is probably of the patient's lifestyle. Since the patient is obese, morbid obesity, he is also a smoker, had an unhealthy lifestyle or unhealthy diet. So pertinent information such as patient's information is that age 44 years old with morbid obesity. He also had a cabbage procedure with multiple stents. First, he was admitted in North Platte, and later in the day, he was transferred to CHI St. Francis. And then in the ER, he presented some symptoms such as hypotension, hypoxia with a GCS score of less than 8, high-grade fever, and a pitting edema of +3. So once he was in the ER, he was initially on NIV because he was settings of less than 90%. He was put on ST mode, and then with the settings of IPAP of 12, EPAP of 8, FiO2 of 60%. And then based on the assessments, the patient's neck size is large since he's obese. And then once he was on NIV, he was immediately transferred to in the ICU. And then while he was on ICU, he was also being hooked with a arterial line. And then still he's very uncomfortable, still hypoxic, which leads to impending respiratory failure. So based on the EBG, it was mostly like alkalotic, but still with moderate hypoxemia. So immediately the physician intubated him with this size of 7.5, lip level 26. So one of the things that I will discuss is the GCS. Since he's having a GCS of less than 8, it necessarily means that the patient doesn't give any response, such as verbal or pain response. And then with the patient's deterioration, the patients did not generate any spontaneous breaths while on NIV or even exhibit apnea, which is the main indicator for putting a tube in or putting an invasive ventilatory support. So because of the patient's respiratory failure, it may attribute to a hypoxemic respiratory failure or type 2 respiratory failure. So, and then with the reason of pulmonary shunting, mainly because of the poor response to NIV. So the patient's chief complaint is shortness of breath and fever, and then he was diagnosed with OSA, COVID positive, and hypertension. So later I will discuss more about being diagnosed with COVID positive. So general appearance for the patient. So these are the things that I've got from the patient: skin color is pale, temperature of 101 Fahrenheit, which is infection, possibly because of fever. Sensorium is comatose, no accessory muscle use, not diaphoretic. Breathing pattern is irregular. Edema of +3, meaning it's more severe in terms of inflammation because it's generating more positive levels, and chest expansion is equal. So other than that, the vital signs: heart rate of 101, respiratory rate of 25, SpO2 92%, while on 60% FiO2, with blood pressure 144/79, and then the intake and output: intake of 3,247, while the output of 1,741. Breath sounds: mostly crackles with bronchial on the upper lobe and mostly diminished in the lower lobe. So in here, the intake and output, as we can see, there's a massive difference in terms of the value. So it necessarily mean that the patient is having hypervolemia or excess fluid. So we could generate and identify it based on the patient's body weight and their pitting edema, such as the +3, and then the decreased lung compliance. So with the breath sounds, basically based on the bronchial and mostly crackles, it necessarily mean that the patient is having a consolidation. So with that, we can possibly figure it out if the patient's having effusion or pneumonia. So what are the basic assessments? So the EKG showing sinus bradycardia, extremities showing large edema, specifically on fingers and legs, have thick copious secretions with mixed yellow-green color. So connections with this is the breath sounds indicate consolidation, which can be heard over the lung periphery, as what I've discussed on the previous slide. So with the breath sounds, it indicates that there are secretions present on the large airways, as evident also with the color. And then edema is associated with the presence of finger clubbing. So when we say finger clubbing, immediately we can say that the patient is having a chronic tissue hypoxemia, which is one of the signs. And then based on the secretions, this would indicate the presence of infection because of the yellow-green color, possibly like acute bacterial infection. So with the EKG, based on the result of sinus bradycardia, it means that the patient has a weak sinoatrial node or the pacemaker, maybe because of the hypoxemia and also because of the patient's decreased sensorium or the less than 8 GCS. And then aside from that, all of these assessments are what I got from this patient. So clinical proof. So chest X-ray showed low lung volumes with multifocal pulmonary consolidation, most consistent with multifocal pneumonia and no pleural effusion. EBG show acute alveolar hyperventilation with moderate hypoxemia based on these values. So immunology, serology confirmed COVID positive through PCR test. And CRP result was 10.40. This is mostly due to a secondary infection such as pneumonia. So with the PCR, this is also called a polymerase chain reaction test or molecular test. This test is mostly common nowadays because of the COVID pandemic. So this test would detect any genetic material of the virus. So on the other hand, CRP or C-reactive protein test, the high result, as we can see, with a result of 10.40, mean that the patient has infection. So before he also had a cabbage, which we can attribute to this result. And this may also suggest that the patient had heart inflammation or any underlying disease which contribute to the results, such as his diabetes, being current smoker and overweight. So in here are the clinical proof. CBC labs white blood cell is very high of 14.3, red blood cells is 3.95, hemoglobin 19, hematocrit is 51.7. All of these are increased. So with the CBC labs, we can immediately say based on the white blood cell being increased that the patient had infection. So it means that the patient has leukocytosis and also with the red blood cells. So meaning there's acute infection or any chronic tissue hypoxemia. So since the red blood cell is increased, while immediately hemoglobin and hematocrit would immediately increase. So both red blood cell, hemoglobin, and hematocrit, since all three of them are increased, the medical term for these are polycythemia. So this meant that the patient could have chronic tissue hypoxemia. So chemistry labs showed glucose 153 since the patient is diabetic, the BUN of 28, creatinine of 1.5, sodium of 160, potassium 5.2, and chloride of 79. So one of the things that also I would discuss with the chemistry labs is the BUN and creatinine. This would indicate that the patient could have underlying kidney problem since it's increased. And then take note also with the chloride. So why is it decreased? It is mostly because it could have been uh, suggestive of the patient's diabetes and his fever and his underlying infection, which are the main cause of the chloride being decreased. So coagulation labs is INR 1.0, which is normal. So other clinical proof is the arterial blood gas. So with these results, as what I've said, it was acute alveolar hyperventilation. So in the interpretation, it was acute uncompensated respiratory alkalosis with moderate hypoxemia. So I would immediately recommend giving oxygen or intubation because it might lead to respiratory failure. We should avoid patient from having respiratory failure. So with the ABG result, the common cause of the result is the hypoxemia. Why? Because based on the values being shown in the slide, uh, it was mainly because of pulmonary shunting, specifically on the capillary side, since the patient had oxygenation problem since he got in the ER. So other clinical proof is the chest X-ray. So taken on October 19, said low lung volumes consistent with multifocal pneumonia. So is the chest X-ray improving? From what I observed from the recent and the previous one, there are specific increase in densities due from the consolidation with increased opacities, meaning I can suggest that the patient could have ARDS, pneumonia. There was also some slightly air bronchograms that I've seen from the patient's chest X-ray. So it is mostly localized in the peripheries. So the connections made is the increase of opacities because it is more diffuse or scattered, which could show that it is more higher in the lower than the upper because of the decreased lung volume of the patient or decreased compliance until it would totally appear a solid white area. Medications, here are the medications, dexamethasone, 10 milligrams IV daily. It is mostly used for anti-inflammatory and immunosuppressant effect. It would help reduce mortality to patients using oxygen or on life support. So on the other hand, dobutamine 500 milligrams indicated for inotropic support for the treatment of cardiac decompensation from heart disease or surgical defects. gabapentin 250 milligrams per 5 ml every 8 hours for anti-epileptic for treating seizures. Humalog 3 units Q4 help improve glycemic control in adults and those patients with diabetes. Midazolam is on 100 milligrams for sedation use during intubation and also used in critical care setting. So based on what I've gathered, the patient was not being given any respiratory medications. So evaluations. So suggestions that I can give to the patient is to provide a lung protective strategy since the patient is hypoxemic and could have ARDS, the low tidal volumes, high respiratory rate, or we can call it permissive hypercapnia. So inhaled ipoprostenol or inhaled nitric oxide, this will help improve oxygenation and reduce pulmonary artery pressures. Prone positioning suggestive of 16 hours proning with 8 hours supine. This would help correct the ventilation perfusion mismatching, shunting, and improve oxygenation. Careful fluid management to reduce fluid overload or edema. We should ensure the goal of the central venous pressure of less than 4. And then the other one is alternative approach and MECVEN strategies using either APRV, PRVC, or ESV modes. So these modes would help recruit the alveoli, allow lung protection or prevent alveolar collapse and minimize work of breathing. So with these evaluations, number one for the proning. Proning is ideal for ARDS patients since this would help improve their PaO2 levels by 10 to 50 millimeters per mercury and also improve their PaO2 within 30 minutes and also help decrease PaCO2 levels. So for the lung protective strategy, the goal is we should lessen the plateau pressure of less than 30 to avoid any incidence of barotrauma. And then the inhaled ipoprostenol or IEPO, this would help dilate pulmonary blood vessels. And aside from that, the IEPO would also improve gas exchange. And then with the modes, so APRV usually it is giving 2 sets of spontaneous breath or CPAP levels, and then it is specifically indicated for ARDS since the 2 levels of CPAP it would help improve oxygenation, treat refractory hypoxemia, and stabilize collapsed alveoli. While ASV mode, it provides the lowest possible peak pressures or PIP with a guaranteed tidal volume and facilitate weaning. Expected outcomes is the patient will exhibit pulmonary fibrosis or scarring of their lungs long term, which is normal for patients who survive ARDS. Some will even have a multi-organ dysfunction or worse sepsis since the infection is spread throughout in their lungs. There are even patients that those patients who survive the ARDS, they will undergo weeks or even months in the rehabilitation area or for physical reconditioning to regain their strength and also to regain their self-esteem. And then some also patients would have a deteriorating physical size of their lungs, about 20 to 30% from their normal size, mainly because of the compliance being decreased. There will also be some minor cases of having caloric deficits, loss of lean body mass, and even a deteriorating respiratory muscle if not being given proper nutrition. Patient presentation, expected presentation for this patient, some, depending on their case to case, may appear average in size, and the actual presentation for this patient, he is obese, And then the patient also should have accessory muscle use, retractions in tachypneic, and then the patient's presentation, he didn't exhibit any distress, but he was tachypneic. Breath sounds, mostly bronchial in crackles because of the consolidation and secretions in the large airways. So the patient too had those breath sounds, but with diminished in the lower lobe. Finger clubbing, yes, the patient also had finger clubbing and even had a presence of edema with positive 3, meaning severe inflammation and more severely hypoxemic. Chest X-ray, ground glass appearance with diffuse bilateral infiltrates. Patient's presentation showed increased densities in the X-ray with increased opacities. And then lastly, the patient mostly would show being agitated, anxious, or restless, and the patient is having GCS score of less than 8 or comatose. So here are the references that I used. So as usual, I used the textbook of clinical manifestations and assessment of respiratory disease for ERDS. I also used this website. This website is very helpful ever since the www.respiratorytherapyzone. Even used the booklet of Oak's respiratory care and using 9th edition. I still use the website for the medications with rxlist.com. And then lastly, I used this reference as my guide, the project table that we used in the previous semester, previous class in the critical care management. So before I end this video, I would like to say to everybody, especially to our instructor, Miss Chris Lewis, thank you so much, Miss Chris, for everything that you have done to us students. You sacrifice a lot for us. You help us a lot. And then shout out also to our instructors as well from other class such as Miss Kelly, Sir Todd, and even from the previous class before Miss Angie. You guys did a good job for all of us. And then we would like to thank you for all the efforts that you have given to us students, not just to my classmates in the online class, but also with the in-class. So with my classmates, I know this journey has been a overwhelming, but it's a memorable one, especially in my personally. So I will never forget this experience. I will always treasure this. And then thank you so much for everybody. And I hope that we'll see each other in the long run. So this is Anthony Dangoy. Thank you so much. And we've made it. Signing off.